EMS coordinators in the network. I apologize for being late. My fault. Today we're going to talk about traumatic brain injury. If you have any questions, just let me know. You can interrupt me. Why are we talking about TBI? What is your highest mechanism of injury for trauma? I don't care what department you're talking about in this area.
Nursing home fall.
Nursing home falls, geriatric falls, right? So we're talking about TBI for that reason. We're going to cover a wide spectrum of TBI, but most of what you're going to see is your geriatric fall patients. And the problem is that we tend to have some complacency with walking in on those patients just because we see them over and over and over again. What are some of your other barriers, though, for assessing your geriatric fall patients? What did you say? Yeah. Yep, all of those things. And then just, like I said, what their baseline is and having a hard time assessing them. Actually, I was at Green yesterday. I stopped by to pick up some equipment, help Tony pull a trailer. Clearly, I didn't help that much, but and we had a 78-year-old that fell walking into the hospital 2 steps up, and so she was far enough out from the ER. We had to call Xenia City. I'm holding C-spine. I'm trying to assess what her baseline is. Her older sister is so upset she can't tell me if this is normal for the patient. She's answering questions, but it's kind of slow. Like, where are we here on the possibility of a traumatic brain injury, right? Because that's what I'm mostly worried about along with C-spine pain. So it's quite difficult sometimes to assess those patients. We are going to look at some AAP, look at mechanism of injury, and then best treatment options and destination for TBI patients. All right, so just to remind you from paramedic school, basic school, how many basics do we have? How many medics? Okay, is that pretty much the breakdown through most?
Yeah, we're about 60, probably close to 70-30 at this point.
Okay. Okay. So remember that your skull is a rigid structure. Okay. Blood vessels and nerves exit and enter through multiple holes, but your biggest possible exit point for your skull is your foramen magnum. So what does that mean if the brain starts to swell? There's really nowhere for it to go. If you were to cut open someone's head right now and look at their brain, consistency would be kind of like Jell-O. It's mostly water. Even when we dissect brains, like if we talk about like cath lab or something like that, at that point we've taken fluids out of the body, and so we tend to have a tougher brain matter. But within your skull, it's more like gel. So it's more like gel, and there's nowhere for it to go because you do have a rigid structure there. And then, of course, your parietal, frontal, sphenoid, temporal, occipital, those are important to remember to a point. Okay? Remember, your right and left hemispheres are your cerebrum. That's where we interpret all of the signals coming to our brain, coming from our brain. So vision, hearing, speech, emotions, fine motor skills. If you think about this, if we send you a follow-up about a stroke patient, it's going to tell you what part of the brain we're looking at for an ischemic stroke based on the signs and symptoms of that patient, right? What are the deficits on that patient? So like temporal lobe is hearing, occipital lobe is what? Vision, yeah, remember like if you've ever smacked your back of your head and you get that like kind of blinding light, that's why, right? Because your occipital lobe processes vision. What's your cerebellum for? What's your cerebellum do?
Posture balance.
Posture and balance, right? So I will tell you I have had cerebellar strokes that we thought were drunk patients, and then they blew a 0 on the breathalyzer. But they didn't have any Cincinnati stroke scale symptoms, right? Other than ataxia. They weren't quite able to walk correctly. But this test was fine. They didn't have any facial droop. They didn't have any slurred speech. They wrecked a car, and you're like, what's going on? Well, they're having a cerebellar stroke, so don't forget that. And then brainstem. What does brainstem do? Your midbrain, your pons, your medulla.
Your functions. Yeah, heartbeat.
All your autonomic functions, heart rate, breathing center. So if your brain swells, we talked about where it swells to, down that foramen magnum, what are we worried about getting knocked out?
Your heart rate.
Yeah, autonomic functions, okay? Now you can herniate sideways in your brain as well. You can have midline shifts and things like that. But ultimately what we're worried about is knocking out that brainstem function. So your ventricles are filled with CSF. You can actually survive without CSF, and there are times in the hospital that we drain CSF from your body. Okay, different procedures for that. But what does CSF do for us? actually don't know everything it does, but we know some things that it does.
Cushion.
It does cushion. What else does it do? It actually helps wash and clean the brain, so you'll get toxins basically that get taken out and reabsorbed with CSF. And you do want to have balance, like if you think about some of your kid population, you have enlarged ventricles and things like that, you can have seizures, and you have kids with shunts and things like that. So you can have hydrocephalus, which is enlarged ventricles, and then you can have syringomyelia, which is collection in the spinal cord. Because remember, it goes all the way down your spinal column, your CSF does. That's what we test for meningitis. Remember that blood in the blood vessels is good in the brain, but blood is actually toxic to brain matter. Okay? So if you have blood directly in contact instead of in the blood vessel, you are actually killing those cells because blood isn't good for brain matter. Okay? And how much does it take, approximately how much does it take before you start seeing signs and symptoms in the brain? Like in a normal healthy adult? Like a teaspoon, not very much. Okay? Okay, so also looking at blood flow, again, we aren't talking about stroke, but they are very much related. So remember the top of your aortic arch sits 3 arteries, your left subclavian, your left common carotid, and your brachiocephalic trunk. Okay? Your left vertebral artery comes off the left subclavian, and your right vertebral and right common carotid come off your brachiocephalic trunk. So brachiocephalic, your common carotids go up, which is why stroke patients, for example, get carotid ultrasounds, right? Because we want to make sure that we don't have stenosis in the carotids, because what will happen is you will either completely cut off blood flow to your brain, or you'll have a clot that breaks off and then lodges somewhere else in the brain, okay? But your vertebral arteries can also get ischemic strokes, and those are the ones that tend to be your large vessel occlusions, your cerebellar strokes, your big ischemic strokes. So when we talk about like intervention, stroke intervention, and things like that, a lot of those are your vertebral artery ischemic strokes. Okay. And then when we enter the brain, okay, here's your common carotid. So then it branches off into your internal carotid and your external carotid. And we're really going to talk about that external carotid and what can happen in TBI. There's your middle cerebral artery, your anterior cerebral, posterior cerebral, and your basilar artery, which is that big one. Your vertebrals run up and join to form that basilar artery. And then you form a circle called what? What's the circle that you form in your brain? Circle of Willis, that's right. What does that do for your brain? What does that allow? It's collateral blood flow, right?
Yeah.
So it's collateral blood flow so that if you do end up with a blockage or a bleed, right, you can actually get blood to other areas of your brain. So that's what we're talking about here, circle of Willis. All coming together, okay? It is a safety feature. Okay, so that's general blood flow. If you were to really, I don't know if this slide's in here. Maybe it's not. If you were to really look at every single blood vessel in the brain, can we actually get to the tiny end blood vessels in the brain? No. It's an entire tree of blood vessels, and we can really only get to some of the larger blood vessels. Okay, these are your meningeal layers. Now they are in the skull, but they are also run all the way down your spinal column. I mean, obviously the skull doesn't, but the meninges do. Okay, so this is an actual cadaver cross section, so that you can see that. So this is your scalp. This is your periosteum, which is the layer that helps lay down bone. Okay, so there's your bone, that would be your skull. Below your skull is your dura mater, which means, does anyone remember what that means in Latin?
Hard mother.
What?
Hard mother.
Yeah, tough mother, hard mother. So this layer does not expand very well. Okay, it's not flexible. It's very fibrinous. Below that is your arachnoid mater, which means what?
Spider.
Spider. That's awesome. Spider. Okay, there's your arachnoid mater, and then your pia mater, which is your tiny layer is actually directly adherent to the brain, kind of like the membrane on the bottom of a hard-boiled egg, right? It adheres directly to the egg white. So your pia mater, you really can't get like sub-pia mater bleeding in any way, okay? And then your brain, actual brain tissue. All right, so here's another cross-section looking at that. You can see where blood vessels enter and exit the skull. You can see how the brain, how the blood vessels run, and how the meninges run as well, okay? So the dura mater does contain a large number of blood vessels, okay? It adheres to the skull, and so when your brain shrinks as you age, it stretches out those blood vessels, right? So if you have adherence to the skull of that dura mater, and then stretching of those blood vessels between the arachnoid mater and the dura mater, why do we get more subdural bleeds in our geriatric population? Yeah, you have those stretching of those blood vessels. It's much easier with a lower mechanism of injury to shear those blood vessels. So you have geriatric patients with chronic subdural bleeds, okay? So we always talk about acute versus chronic with them, okay? And then the spider-like appearance is all those blood vessels entering and exiting the arachnoid mater. CSF is located in the subarachnoid space, and then we talked about the fact that the pia mater adheres directly to the brain. So you can see, again, layers of the meninges there. Okay, so what counts as a TBI? Like if we classify it when we check patients into EPIC, you look at your ICD-10 or your ICD-9 codes, what counts? So any external mechanical force that causes brain dysfunction, so we're talking all the way from mild concussion all the way up to major brain bleed, those all count as TBI, okay? It can be blunt or penetrating, so skull fractures, intracranial injuries, anything to the optic nerve and pathways, shaken baby syndrome, and any unspecified head injury. All right, so looking at common mechanisms of injury, and this is CDC data from 2002 to 2006. We can get some other data from ACS, but it just depends if like you have an ACS state and things like that. But this pretty much holds true if you like go to stores, you'll see the same mechanisms. Falls make up the majority of our MOIs for TBI. 21% is unknown, 17% vehicle, 10% assault, and then 16.5% struck by or against something. So the one we just want to talk about briefly because it's easy to see if there's a hole, right, in someone's head. Oh, they got shot in the head. This one was a nail gun to the head. What are we going to do for those patients? What are we going to do as EMS? Yeah, like not a whole lot. We're going to want to make sure that their autonomic functions are working if we can, but other than that, they need to go to the which trauma center? What?
Kettering.
The level 1 or 2. So depending on where you are, because some of you may work in other jurisdictions. Yes, Kettering is a level 2. The Valley is a level 1. Why don't we, in general, want to take this to a level 3? Now, there are cases where we should take things to a level 3. If you're in an outlying department, it's greater than a 30-minute by ground transport, then you want to consider helicopter or stopping at the level 3. And if you alert them on time, A, they might have a trauma surgeon that's able to stabilize there, or B, they will get transport to them quicker to ship the patient out faster. Okay, so there are appropriate times to take it to the level 3, but for you guys sitting in Washington Township, why are we taking it to the level 1 or 2? What do they have that level 3s don't have to have?
24-hour staff surgery.
Neurosurgery,
Oh, okay.
yeah, neurosurgery and interventional neurology. So no one technically has to be in-house. Level 1s and 2s, the trauma surgeon has to be at the bedside for a Cat 1 trauma within 15 minutes of a page, whereas level 3s have a 30-minute window. Most level 3s I know, their surgeons get there faster. But that's why it's based on drive time, like in your protocols. So follow your protocols. But that's why, because level 3s only have to have general surgeons who are trauma trained and orthopedic surgeons. Now, places like Grandview have a lot more specialties. Boeing has a lot of specialties. They have more specialties than that. The only thing they have to have is orthopedics in general. The level 1s and 2s have to have neurosurgery and interventional neurology available. Okay? So that's why this has to go to a neurosurgery place. What's this? Vital signs for what? Basilar skull fracture. Okay? And then raccoon eyes, same thing. How do you know that you have raccoon eyes versus a black eye? Yeah, you're going to get, if you get a mechanism injury where they're struck in the face, you should have bruising on the orbits around the eye. That's not occurring here. You have puffiness and bruising directly on the eye. All right, so societal impact of TBI, it is a major cause of disability in the United States. Okay, so it's increased need for medical care, rehab, and then cognitive and physical function. So typically with trauma, what we say is we would like to rehab the patient to the same or better than they were prior to the injury. When it comes to brain, our goal is typically that you are able to clean yourself and feed yourself. Okay, so we don't quite have the same amount of access to obviously blood vessels in the brain. So why are we talking about this with EMS? Well, this was a study by the American College of Surgeons Committee on Trauma. They're the ones that set all the guidelines for transport, for MOI. The state of Ohio reflects those guidelines, and then we reflect them in our local protocol. And basically what this says is EMS doesn't always do a great job of identifying TBI, and when we do identify it correctly, and then we get the patient to the right place, we have a major impact in the morbidity and mortality of our patients. So a lot of this is geriatric patients, right, who have sustained a head injury, and we under-triage them. Then we don't get them to the right centers, and then we do create problems on the road for our patients. So this says transport your TBIs to the level 1 and level 2. And that GCS score, specifically a trending GCS score, is the strongest predictor of death among patients who have sustained head injuries. Okay? This says, this one was about rural departments, that aggressive early identification and treatment of TBI patients is necessary. So again, flying them when needed when you have a greater than 30-minute ground transport time. And that our geriatric falls, again, across the country, not necessarily in this area, we're not even taking them to trauma centers. So even if you got them to a level 3, you would have resources there to identify a little more quickly if you had a high level TBI, but we're not even doing that all the time. Sometimes we're just taking them, oh, it's the local nursing home, we're taking them to the local hospital because they fall all the time, right? Well, the problem with that is that we're not identifying TBIs and we're actually causing harm to our patients. We talked about neurosurgery. Okay, so what classifies? All right, so now we're just talking about what classifies as a mild versus moderate versus severe TBI, and then we'll talk about what the threshold is for transporting our patients. So mild TBI is going to be loss of consciousness of seconds to minutes and a GCS between 13 and 15. All right. Headache, long term, you can have nausea, vomiting, difficulty sleeping, sensory problems. If you think about the athletes with, TBI has really come into the news with athletes lately. This is where a lot of them sit. They just get these mild concussions over and over and over again, but then they have long-term side effects that affect their ability to study, their ability to sleep, concentrate, read, long-term in school. Okay. Moderate to severe TBI is a GCS of, well, for moderate 9 to 12 and severe less than 8. This loss of consciousness is minutes to hours. And then this is where you're going to have like repeated nausea, vomiting, convulsions, seizures, clear fluid draining from the nose or ears. What is that if that's happening? You've got clear fluid from the nose or ears.
CSF.
That's CSF. That's bad, right? Can't wake them up from sleep, loss of coordination, profound confusion, agitation, combativeness, slurred speech, coma. Okay? And remember, we're talking about patients who have a mechanism versus a hemorrhagic stroke that just happens. Now, realizing that, how many of your geriatric patients are they just got found down, right? You have to assume that a found down patient that was not witnessed is simultaneously a brain bleed, a major trauma, and a cardiac event until you have more testing to figure out what it is, right? And I know overdoses too. I'm aware of that. All right. So, any questions on the difference between mild versus moderate to severe TBI?
Would like a concussion fall under the moderate, or I'm sorry, the mild?
Yes. Typically, it's going to fall under mild TBI.
Like car accident, they get knocked unconscious for a few minutes, that's mild, not moderate.
It can be. It just, what we're really looking for is trending GCSs, right? So if you arrive on scene and they're totally unconscious, but then within 5 to 10 minutes they're 15, well, I want to know what they are, you know, if they're unstable every 5 minutes, if they're stable every 15 minutes for an hour, what's happening with them. Because if you have a patient that wakes up for 10 minutes and is a 15, but then all of a sudden starts going 14, 13, 10, okay, that trend is significant. So it's your trending GCS. And actually, the funny thing about GCS, does anyone know why, when the doctors that came up with this, why is the minimum score a 3 and not a 0? Does anyone know? Because they wanted to make sure that it was actually done. They wanted to make sure that it was actually evaluated instead of just saying, oh, it's a 0 and whatever. And they didn't mean to make a score that predicted outcome, they just did. So they made a score that could be universal so that they could talk over the phone and talk about their patients and figure out what the level of consciousness was, but they accidentally came up with a score that trending it predicted the outcome for the patient. Okay, so this is a slide talking about babies, and I just want to talk about this quickly with head injuries in kids and also seizures in kids. Remember that when baby's born, you don't have full myelination of all of your nerves in your brain, okay? So do little babies get big tonic-clonic seizures? No. What could be some signs and symptoms of a major grand mal seizure in a little baby?
Febro.
Could be, okay, if you have a febrile seizure, that's different. Yeah. Okay, eyes, yeah, if your eyes are shaking back and forth, anything rhythmic, like, right?
Looking off to the side.
Looking off to the side, yep. Any rhythmic cry, those are all signs and symptoms of a seizure in a little kid, because the only fully myelinated nerves that you have are like your sucking reflex, your breathing, your heart rate, things like that. You don't have fully developed other reflexes in a little baby. Think about the huge development you have in a kid from birth to a year old, okay? So by the time they hit a year, they may have a big tonic-clonic, but for little babies, anything rhythmic like that, and you can do a couple things to try to see, is this kid just crying or is they seizing? If you put your finger in their hand, a little baby should grab onto that and it should kind of break the rhythm of what they're doing. And you can say, oh, no, they're not seizing, they're just crying. It kind of sounds rhythmic to me. Or they will completely ignore that stimulus and continue the rhythmic, like I said, sucking sound or crying sound. So think about that in little kids. So it can be something as simple as unusual irritability, change in nursing or eating habits, change in sleep habits, loss of interest in activity, so many things in little kids like that. And then what other kind of warning signs would you guys consider on scene if you go on a little kid, especially if you suspect abuse?
Stages of bruising.
Yeah, like
Yep.
the bruising or
Especially if it's hidden, right?
yeah,
Tickles.
It tickles.
Shoot.
Tone interactivity,
Yes.
consolability,
Yep.
look, gaze.
How will parents be acting on scene?
Very protective. Sketchy.
Weird,
Yeah.
right? Either
Overprotective.
overprotective where they don't want you touching or
Not
assessing
wanting
your
you to take
kid.
lift their shirt up or take them out of their car seat or
Right.
they wanted to keep them in a blanket the whole time. So,
Right. Or they don't care at all.
Yeah.
One of the two, typically, okay? So if it doesn't feel right, just keep that in mind. If it doesn't feel right, it's probably not. Your duty is to report things, obviously, with some evidence. You can't just have a funny feeling and no evidence whatsoever, but your duty is to report not to be right, okay? So those can be, but it could be, like I said, like even like a 5-year-old who hit his head and didn't tell mom, but ended up with a mild concussion. These are some of the signs and symptoms that you might be looking for. Okay, so any questions about what constitutes moderate to severe and mild in kids? Any questions on those? Okay, so now we're going to jump into talking about bleeds. Okay, not everyone who has a TBI has a bleed. Like I said, they can have a concussion instead. We're going to talk about bleeds. So epidural hematomas are typically trauma only, and the reason they're trauma only is because they're typically from a side impact injury to the head. What are some examples of very common side impact injuries to the head that we go on all the time?
Falls, car accidents.
Yes, car accidents, particularly which kind?
T-bones.
T-bones, right? Because they plow into the side of that car and then bam, yep, smack against the V-post, smack the person next to them. The side impact airbags are great, but not every car has them. And then what typically happens is you end up with that tear in that middle meningeal artery. I told you we were going to talk about that. It runs just under the skull here. And so when you whack your skull here and you end up with a sharp edge, you'll typically tear that artery. So epidural hematomas are typically arterial bleeds, which is why it's showing up white on this CAT scan. Okay? And it's associated with skull fractures. This is the textbook is a brief loss of consciousness followed by a lucid interval, which can be seconds to minutes to hours, depending on how fast the bleed is, and then slowly losing consciousness pretty badly. Okay? Other epidural hematomas I've seen are as simple as like Edna falling sideways out of her wheelchair, and like half of these geriatric patients are on blood thinners. Cardiologists love blood thinners, trauma docs hate them. So again, remember, your geriatric patient does not have to have a high mechanism of injury to have that happen. Okay? Falling off a bike without a helmet, I've seen a lot of those with epidural bleeds. Okay? So what are we going to do for an epidural bleed? We're going to go in typically, because it is arterial, it usually needs quick intervention surgery. So we will do exactly this, take off the skull and evacuate that clot, suck it out, and then cauterize the artery. Okay? So epidurals typically are going to require neurosurgery. Okay, subdurals. So below the dura mater, we talked about that space and those bridging veins and why our geriatric patients shear those blood vessels fairly easily. This is venous bleeding, typically. It's typically not arterial. You can tear your cortical artery, but again, most subdurals are venous. And acute subdural hematoma can take up to 14 days from the time of the injury to appear. Keep that in mind with your geriatric patients, right? Why do elderly patients take longer to develop any signs and symptoms of a TBI? So we talked about the brain shrinking.
Low blood pressure and their blood vessels are stretched out.
So do you have more room in the skull or less room?
More.
You have more room, okay? So it's going to take longer, so you're going to have more blood by the time you get to more severe symptoms in a geriatric patient typically, compared to your healthy adult patient. Then the problem with this, with the patients that develop chronic subdural hematomas, the clot forms, and we think we've stopped the bleeding, and then the body's like, cool, I can start breaking down that clot because we're done, right? We're done with this bleeding. But then when it starts breaking down that clot, it just kind of liquefies the clot, and then there's like just a little bit of bleeding that occurs again. So you do have patients that they just watch the subdurals, even in the nursing home. That can happen. All right. If we do have to evacuate a subdural hematoma clot, we can. So we can flap back the skull, cut through the dura mater, and then go in, again, suction and cauterize. But subdurals they don't need neurosurgery. A large one will, but they don't always need surgery. Sometimes we just watch them and wait for them to stop. Okay, so again, epidurals, typically arterial blood, skull fracture associated, and then venous can be pretty much anywhere under the dura mater. Questions on that? epidural versus subdural. So your subdural patients, neurologically speaking, are the ones that are going to typically have more mild symptoms, but if they do have a severe subdural bleed, it will still be a slower progression, right, into those bad symptoms, as opposed to the loss of consciousness, the lucid interval, and then, oh crap, my patient's doing poorly, all right? It's going to be more of a gradual decline for those subdural patients because venous bleeding takes longer. Make sense? Yep, okay. Subarachnoid hematoma. Below the arachnoid mater, it's not a discrete clot, meaning looking like that, where we could actually go in and suck it out. It's usually non-traumatic. If you see a subarachnoid bleed, typically it's a hemorrhagic stroke. Okay? And you can see how diffuse this is. All that white through the CT. Okay? Again, you can have cortical arterial bleeding, but the problem is there's nothing to go in, do surgery, and suck out that clot. Intraparenchymal bleeding, this is 13 to 35% of your severe TBI patients. We look at this in stroke too, whether it's a hemorrhagic or ischemic, but when you cut off blood to the brain and or you put blood on brain tissue, you create this area that is junk. That's not the medical term. But you have edema, so blood is toxic to brain tissue, and then swelling and edema are really bad for brain tissue, right? Like if you have edema and swelling to your arm, yeah, it's not great, but eventually it's going to go down and be fine. Whereas with brain, you're creating that area of injury that keeps getting larger and larger and larger, okay? So commonly this is in the frontal lobes or temporal lobes. You can see here on the CT and here. And the reason that this happens with TBI, because it can happen with stroke as well, and it's just spontaneous. But the reason intraparenchymal happens with TBI is because the backside of your skull is rough and bony, and so this is what you typically see with those coup contra coup injuries that are frontal impact, right? So the car stops suddenly, and then you stop suddenly, hopefully you're wearing your seatbelt, and then your brain goes like that in your skull, right? So it hits the front, and then it hits the back, and because the skull is fixed and it's also rough and bony, you end up with those signs of impact, okay? So they're usually from deceleration injuries when we're talking about TBI. And then, like I said, so if you see the actual bleeding here that's white, see this dark area around the bleed? That's all that edema and brain tissue that's damaged. So it's very similar to when we talk about MI and we talk about trying to revascularize that area so that we don't end up with dead tissue. Same thing with brain, okay? And part of when we talk about ischemic strokes and whether or not you should get TPA, one of the things we worry about is that the softer this brain tissue becomes around the site of ischemia, the more likely it is to convert to a bleed, okay? Like I said, I know this isn't a stroke lecture, but they're so similarly, I mean, we're talking about the same organ, so. So that's typically what your intraparenchymals are from. Can you have more than one type of bleed? Yes, you can, based on mechanism of injury, okay? Those patients don't do so well, right? Intraparenchymals are the patients that typically do the worst. And that's what I was talking about, that coup contra coup injury. So you can really see it on this CT. Bam, there's the initial site of impact, and then you have a little bit of bleeding back here. Okay. So you're not going to be able to see a bleed, right, in the field. You can guess based on assessment, you can guess based on mechanism of injury, and what you're seeing, that this is what you think you have. But we have to assess with no CT, and we have to be able to look at our vitals and say, how bad is this patient and where are they going? So first thing that I want to know with any patient, but with a TBI patient, is can they protect their own airway? Now that's different than are they breathing spontaneously. And we know that's different because we pick up drug patients all the time that are really at risk for aspirating because they're so drunk. They're breathing on their own, but they're going to eventually inhale their own vomit or their own spit, right? So even though airway and breathing are related, I need to assess them separately. So can this patient protect their own airway, yes or no? 2, can they actually oxygenate themselves? This is a great, anytime you have an unconscious patient, stick them on capnography. I mean, There's no reason not to. It's not that expensive and it's a good assessment tool, okay? And, you know, that questionable geriatric patient that's found down, they could also be septic, right? So capnography is going to be a great tool for you. Now, if you have a patient with a low GCS, like hanging around 8 or 9, do you guys have RSI? Okay, if you don't have RSI, what's a really great airway to go to? Yeah, nasal, okay? Don't forget about your nasal intubation. I know it's out of favor because of Kings and LMAs, but do Kings and LMAs really capture the airway? Not really, okay? What you have to check for before you do that, mid-face stability, right? I will tell you that EMS is way more worried about mid-face stability than the critical care nurses on the helicopter. They nasally intubate all the time because they are comfortable assessing for LaForte fractures. They know what will happen if they have one. So they know how to assess it easily, so they know that most of their patients don't have LaForte fractures and they can still nasally tube them. So that would be an area where, you know, learning how to assess that, maybe looking at some videos of patients with LaForte fractures would be a benefit for your patients. Okay, then I want to know, can they oxygenate themselves? Which maybe because they can't, maybe I do go to an airway. And then are they perfusing, okay? Are they showing signs of hypotension, of herniation, or increasing intracranial pressure? We'll talk about all three of those. So I want to trend their GCS, and I want to keep them warm, but not hot, which warm probably means you should be sweating, but not hot. Okay, because one of the things that happens when your brain goes out of whack is you lose your ability to do what?
Regulate temperature.
Regulate body temperature. That's why your sepsis patients can either have a fever or be cold, right? If they're cold, that's real bad because they've passed the curve where they had a temperature and then they went back down to normal temperature and now they're below that. They're not compensating. Okay, so there's GCS in adult. Trauma patient, when you call in, try to break down your GCS. Like, it's great that you give the trauma centers a total, but they actually want to know where the deficit is. Okay. Any questions about the difference, like, between inappropriate words and incomprehensible sounds? Inappropriate words is I asked them a question and they came back with an answer that, like, just, it's words, but it makes no sense. Incomprehensible sounds is they're trying to answer me, but it's just babble, right? That is an appropriate distinction that you need to make. And then confused is like, I kind of get what they're saying to me, right? They're answering questions, but it's not quite the right answer, okay? What's the difference between localizing pain and withdrawing from pain? So obeying commands is easy. What's the difference between a 5 and a 4?
Localizes is being able to tell where it is, and withdrawals is they're like retracting from it.
Regarding it, would that be
Yeah,
one?
like
Right, so if they're withdrawing from like a specific site because that is the site of pain, that's more, localization, whereas withdrawing from pain is just in general, right? They're like, if you touch them and it hurts, they withdraw, okay? Because obviously, like, if you had a totally conscious patient who just couldn't move their arm because their arm was broken, but could tell you where the pain was, like, that's a 15, right? That's still a motor response of 6. And then flexion and extension. Flexion is dequadruped and extension is decerebrate posturing. Both very bad. Have had some fire departments not recognize posturing and then not give an airway appropriately because they scored the GCS higher than it actually was. So watch for that. All right, so pediatric, again, we're really talking about nonverbal pediatrics, typically under the age of 3. 3-year-olds, you can assess them. So if you notice with nonverbal peds, you are going to have a higher index of suspicion, right? Because like my 3-year-old sometimes is inconsolable when she cries. That's just what it is. But if you have that mechanism, you're not sure, and you can't even get your baby to be comforted in any way, you can't get any orientation to objects and interaction with their environment, that's a 4 on the verbal scale. So, I mean, if they're upset, I understand that, but if they're still appropriately interacting and following objects and tracking with you and things like that, and they're like 2, I would understand that they're upset that they just were in a car accident. If they're a baby, I don't know that I can tell that. So if they're crying but kind of consolable, but their interactions are inappropriate, that's a 4. If they're inconsistently inconsolable and moaning, they're not tracking with you, they're not focusing on you, that's a 3. And then inconsolable and agitated is a 2, and then no response is a 1. And then the motor skills are very similar as to adults. So spontaneous and purposeful movement, withdrawing from touch, withdrawing from pain, flexion to pain, extension to pain, no response. So any questions about nonverbal kids? Okay. All right, so goals of TBI management. 1 is adequate oxygenation and normocapnia. So any one single episode of hypoxia, less than 90%, not sustained hypoxia, one single episode of less than 90% pulse ox has shown increased morbidity and mortality exponentially for your TBI patients. Okay, so adequate oxygenation and normocapnia, so we want a pulse ox above 95%. We want to both avoid hypotension and avoid herniation. So we talk a lot about herniation and too much intracranial pressure, but we also really, really have to avoid hypotension. The brain is super sensitive to blood pressure. We want to maintain normal thermia. Again, if the brain is injured badly enough, it cannot self-regulate temperature. We want to have a good normal electrolyte range, which worsens with cerebral edema, because if you can't shift your electrolytes across to your brain cells. Normal sugar. We want to avoid anemia, avoid coagulopathy. What's that a fancy word for? What's coagulopathy?
Too much.
Inability to clot. Okay? And then you want your intracranial pressure range to be between 20 and 25 millimeters of mercury, which we will talk about each of those steps. So the point, though, is that with TBI patients, you're not just worried about one extreme, you're worried about both. You have to maintain their body temperature normally. You have to maintain their electrolyte level, their sugar, their blood pressure, all in that range. It's not just we're only worried about herniation. We're worried about both hypotension and herniation. And that's an important distinction. Okay? So we talked about this. Hypoxia isn't always corrected by supplemental oxygen, right? Like if you're not actually perfusing out to your cells. So, especially in severe TBI, so GCS of less than 9. And they can't maintain their own airway. So we want to maintain capnography between 35 and 40. That's why I said slap some capnography on your patients. Okay? So really, really, really have to manage airway and breathing in our TBI patients. All right, how do we manage C? So circulation, or what we would probably call perfusion. All right? This is your Monroe-Kelly doctrine, right? So we said the cranial vault doesn't expand. You have blood, brain tissue, and CSF. Okay? So if you expand one volume, the other elements have to decrease. And if you're talking about decreasing, we talked about this, there's only one way for this brain to go, which is down through the brainstem. Like I said, it can go sideways first and then down, but eventually it's going to herniate somewhere. And then you're going to end up with profound neurologic damage and death. Does that look familiar to most people? At least briefly familiar? Okay. So what we usually mess with is this and the size of this when we talk about trying to prevent this. So cerebral perfusion pressure is the pressure gradient that drives your blood flow up to your brain. Okay? If you think about it, because your brain is under so much pressure, your body has to overcome both gravity and the pressure in the skull to just get blood flow up to the brain, like on a good day, right? So normally the brain auto-regulates this. Despite your autonomic, your body changes in blood pressure, your brain adjusts and figures out how to get blood flow to itself, and not too much. So normally cerebral perfusion pressure is 70 to 85. You can't tell that in the field. You'd have to stick an actual monitor, which we do in the ICU to measure cerebral perfusion pressure. But you can calculate it, it's mean arterial pressure minus intracranial pressure. So what happens if you swell your brain, if you have blood on the brain, or for some reason you have too much cerebral spinal fluid? Okay? Well, your intracranial pressure is increased, right? So we already have a variable that's out of whack. Well, if you look at that calculation, your mean arterial pressure, meaning your blood pressure in your body, does have an effect on can I get blood to the brain, right? So I've already increased this. I need to make sure that I actually have to increase my MAP initially in order to overcome that intracranial pressure, okay? So this is why a systolic of less than 90, just like a pulse ox of less than 90, is a huge predictor of mortality in TBI patients. Yes, I'm worried about herniation, but I would rather be on the high side of a systolic, not all the way up to herniation, but I'd rather be on the high side of a systolic than hypotensive, okay? This is why your protocol, your permissive hypotension does not count if you think you have a TBI, right? Because we have to maintain a systolic above 90. Don't let it fall below 90, okay? You want to maintain that MAP of 65. That's what you're aiming for. Does that make sense? So initially, your body is going to increase its blood pressure in response to increasing intracranial pressure because it's fighting, right? You got more pressure in the top of your skull. Your body has to overcome that in order to get blood flow. If it does it too much, because we have bleeding, 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 or swelling, 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 yeah, that creates a problem. But being too low also creates a problem. That's why I said it's a range with blood pressure. So that's why I said maintain your capnography between 35 and 40. You will see changes on your capnography before you see blood pressure changes. So monitor your patients. They will have a downward trending capnography with hypotension following. So we don't titrate fluids to the capnography itself. It's just going to be a warning sign to you that like, hey, hypotension's coming, try to get a line on this patient. Does that make sense? How you're going to use your capnography? Okay. All right, but on the other end, we also want to avoid cerebral herniation, okay? Management of ICP is super complex in the hospital, and what we do in the field is a Band-Aid until we get to the hospital. And it doesn't always work, okay? So management of imminent herniation in the field is just a temporizing measure because if you pump too much oxygen and cold air and you shrink your veins, which is your goal, if you think you're going to have herniation, but if you do that for too long, then again, you're not delivering blood to the brain. So we don't do this long term. All right, so signs of increasing intracranial pressure and imminent herniation. This is Cushing's triad. Widening pulse pressure. So if you have a super high systolic of like 200, how do you know that it's a cardiac blood pressure problem versus a head injury problem? Yes. Yes. So if you have a cardiac problem, which by the way doesn't mean that you won't create a brain problem eventually, you'll have a narrow pulse pressure. Your diastolic will also be high with your systolic. Now, I personally had a friend that passed away because she refused to take her blood pressure medications and eventually her brain just spontaneously bled because her systolic was so high. So they're not unrelated. But if you have a cardiac or a blood pressure problem, you're going to have a narrow pulse pressure. Increasing ICP is going to be a widening pulse pressure. So that diastolic will stay the same or even lower, and then your systolic will just take off. Bradycardia, and then abnormal breathing patterns. You start having those three, you have signs of imminent herniation. You are starting to herniate into your brainstem. So what are we going to do in the field? Yeah, drive faster. Lights and sirens for sure.
Hyperbreathing.
Yes. So you're going to, sorry, that's the breathing patterns. You're going to hyper oxygenate, right? We don't hyperventilate anymore. What tool are you going to use to do that? Capnography. What's your aim?
45.
Okay, so normal is 35 to 40. If you're hyperoxygenating, your goal is
25 to
30.
30.
Right on the dot, 30. Okay? Only if you have Cushing's triad, though. All right, and these are the abnormal breathing patterns you're going to have. If you're a neurosurgeon, it will tell you where the herniation is occurring. I'm not that good. But if you have any of these normal breathing patterns, Cheyne-Stokes is probably your biggest one, where you'll hear that increase and then decrease and then a period of apnea. But any hyperventilation, cluster breathing, all of these are abnormal breathing patterns. And you can see that you're getting lower and lower and lower and lower into the brainstem. So what Cheyne-Stokes is going to happen first because it's higher up in the brainstem. And then you're going to progress through these. Other signs and symptoms, any dilated pupils, especially one pupil that's dilated and then turned outward. Okay? Paralysis of arm and the leg on the opposite side of injury, and then decerebrate posturing. Okay, so again, maintain a good ventilation rate, about 1 breath every 5 to 6 seconds, high flow oxygen, and then 10, like your normal breathing rate plus 10, or using your capnography to 30, right there. So for peds especially, whatever their normal breathing rate is, plus 10 per minute, or this is still a better reading, your capnography is 30. Okay, and like I said, what hyperventilation does is it temporarily vasoconstricts to try to decrease the swelling to get you to the hospital in the first place. Right? Well, what are we going to do in the hospital? We're going to, if they're bad enough, take them to surgery, flap open their skull, and allow the brain to swell out into the air. Okay? What are you running massive risk for when you do that? Infection. Yep. Sometimes we're going to instead use hypertonic saline and basically draw all that water and swelling out of the brain into the bloodstream and then have them pee it off. Okay? So we're going to talk about what the thresholds are for that, just so you know what happens to your patient. Okay? So we do monitor ICP. That doesn't replace neurologic exams by a clinician or getting multiple CTs. Okay? We do all three of those things. So it is based on your GCS, right? If there's any structural damage, and if you have any extracranial injuries that require surgery, because sometimes we're monitoring your TBI, but you also have like a splenic lac that needs repaired right away. Well, we're going to be a little more aggressive with you in regards to your TBI since you actually survived your splenic lac surgery. That's what external ventricular drain is, and we like these because they measure ICP, but then they also allow us to drain CSF off the brain if necessary. So if it gets too high, then we can drain this off. So if you walk through the neuro ICU at Kettering or the Valley, you're going to see these. And then here's the drain system as well. So tier 1 is we're going to elevate the bed 30 degrees. We're going to use sedation if necessary to intubate this patient. Give them a ventricular drain. Continuously monitor ICP and then drain if necessary, and then do repeat CTs and repeat neuro exams. Tier 2 is that isn't quite working, so we're going to either give mannitol. Older docs typically like mannitol, the newer docs typically like hypertonic saline, and we're going to try to draw that fluid out of the brain into the bloodstream and have them pee it off. Okay. Again, this becomes more complicated if you have a multi-trauma patient whose kidneys are also shutting down, right? So you can see the balance of monitoring these patients. So this is what we're doing, right? Most of the time we try to give isotonic solution in the field, but if we're giving hypertonic, then we're drawing the water out of the cells back into the bloodstream. Again, we're going to maintain oxygen and everything else at a normal rate. And then tier 3 is you're so bad that we do that decompressive hemicraniectomy. So we'll either flap open the skull like that, or we'll just take the skull completely off. Now when you flap it like this, you can do one of two things, and it's based on how healthy your patient is. You can either sew it into their abdomen to store it there until they're ready to put the skull fragment back on, or you can send it up to the lab to get cleaned. Or if you're Cousin Eddie, then you get a government piece of plastic, so. That's what that looks like in the OR. But again, not every patient with herniation gets this, it just depends. All right, any questions about that? And I did want to mention, check your sugars, right? I know that like a major trauma patient, that's not always something we do, but we said we want to maintain normal sugar in a patient between 80 and 180. Okay? Anytime you have a neurologic deficit, you should always check your sugar. And I was guilty as a nice person of forgetting that sometimes, and ending up 3/4 of the way to the hospital and being like, maybe you should check your sugar on this patient. All right, long term. We don't just randomly decide whether a patient's going to have a good outcome. We use actual diagnostic tools. So we have a prediction model for your 6-month outcome for your TBI, which is your Glasgow Outcome Scale, and then the crash or impact calculator, which talks about long-term over months and years. And we also do things like EEGs to measure if you have brain death or not. So this is talking about how we decide what to tell the family about withdrawal of care, long-term care, just all those prognostic decisions. Like I said, it's not like just based on the surgeon's opinion. We actually have tools that impact where we take this patient. And then some patients, they don't recover, so we have nutrition that we have to consider, tracheostomy that we have to consider, and then DVT prophylaxis, right? Like if they're not ambulatory. Okay, so boiling all this down for us as far as triage transport. If a GCS is less than 13 on a normal adult patient, then we rapidly transport them from the scene to the highest level trauma care. Well, less than 13, what did we say that was? A mild or moderate or severe TBI? It's on the lower end of mild, okay? So less than 13 needs to go to the 1 or 2. Again, is that by air? If you're way out there, does that mean you stop at the level 3 but you pre-alert them? All those things are good considerations. Patients with a combination of GCS of less than 15 and severe extracranial injuries should be transported to a level 1 or 2. So you can have a GCS of 15, but if you have a skull fracture, they need to go to the 1 or 2. Okay. Ultimately. Again, this is the state of Ohio, which reflects ACS, which our PAB uses to make our local protocol. So there's your trauma triage guidelines.